going to do is we're going to go ahead and start our Q&A. So throughout the event and throughout this year, we have been asked just some really tremendous questions from various events from those people in the audience. And we might get some questions today as well. We do have a chat feature for everyone. And of course, those who have registered have also submitted questions. So what we're going to do is we're going to take a look at those questions and we're going to try to get to as many as possible in this time that we have. That being said, our first question I'm going to ask to you, Dr. Wickman, and that is, if I have joint pain, how do I know if I should move more or move less?
That is a really great question. I think ultimately movement is so important for our health that I am very hesitant to say, oh, this would be a good time to move less. That's rarely something that we want to recommend for patients. What I tell people is I think about it in terms of pain and function. When your pain is so significant that it's limiting your function, limiting what you've been able to do, that's when it's a really good time to come in and get evaluated so we can figure out a diagnosis, figure out what is that primary cause of the pain, and develop an individualized treatment regimen to be able to help you maintain the active lifestyle that's so important.
That is wonderful. And I kind of going off of that, I would ask the question, although I think you did answer that, but I just want to ensure, how would someone know when to stretch or exercise, or is that a fine line between doing more harm than good?
Great question. So I would say, it can be really challenging because if you are somebody who is really active or does a lot in terms of day-to-day work or exercise, sports, whatever, you may be used to a little bit of soreness here and there. So that's not necessarily abnormal. But when something is sticking around and is becoming to the point where it's debilitating, it's getting in the way of your performance at whatever you want to do, that's when I would definitely say continuing to push through that may do more harm than good, and getting it evaluated first is definitely the recommended approach.
Perfect. Thank you so very much. Our next question, I'm going to shoot over to you, Dr. Watson. Can repeated cortisone injections or PRP cause damage after a certain amount?
Cortisone is the strongest anti-inflammatory we have. In an injectable form, you can put it right where you need it, where the most of the inflammation is. Cortisone, as it decreases the inflammation, people start doing some of those detrimental things, sort of as you talked about in the first question. That's why one of the things I always tell people is the fact that when you do cortisone, you got to look at the big picture. I always talk about a multimodal way to treat inflammatory conditions, activity modification, avoiding the things that really lead to it. Therapy, stretching, strengthening is very critical. That's why I encourage people to do physical therapy. But the cortisone itself, being the anti-inflammatory, takes away the pain. People start doing things again, and it leads to more destruction, more injury, more cartilage loss. The cortisone itself can also be detrimental to the articular cartilage. PRP itself being a lot more natural, being the body's own platelets, has more natural healing factors, is not as detrimental to the cartilage, a lot more difficult to get, especially if you have those difficult veins and you're a difficult stick. It can be challenging to harvest. Yes, Lee, it's more beneficial, but more difficult to do, has less potential side effects than the cortisone, but all of those things need to be combined in a full picture to help control the problem, to limit the progression of the arthritis.
Wonderful. Thank you very much. Dr. Pierce, we did not forget about you. This next question is going to you. How does osteoporosis affect joint replacement surgery?
So it's actually more so a bit more technical, because osteoporosis is really just a weakened bone. It's not that it's unhealthy bone, if you will. So for example, it's really a bit more during the time you're actually doing the surgery. If somebody that we know has significant osteoporosis, you actually have to just take into some considerations while you're actually doing the surgery, because their bone is not as strong. It won't affect really how they're healing after surgery, or frankly how if they have a joint replacement is in, their osteoporosis doesn't really change the course of their healing. It's just that because their bone is weaker, we as the technicians have to be more cautious actually while we're doing the surgery, because you obviously don't want to have a fracture or something that the person didn't previously have. So for example, when we do hip replacements, if somebody has a known history of bad osteoporosis, we may actually use a different technique to put their hip replacement in than somebody who is either, say, younger or just simply doesn't have a history of osteoporosis. But the fact that they have osteoporosis alone doesn't really alter, how we would rehab them, or how they would recover, or frankly, how they would heal. They're going to heal the same way. It's just because they have weaker bone to begin with, you almost have to be a little bit more cautious, just simply taking care of that person, at the time of their surgery, if that makes sense.
Oh, that makes perfect sense. Thank you very much. That's good to know. I think that's kind of something that we take a step back and we're like, well, is the recovery different? But that's really great to know that that's something that you're considering on your end,
right?
And less of something that, somebody recovering from surgery would have to consider.
Correct.
Dr. Pierce, I want to ask you another question. Let's say somebody is just starting with intermittent hip pain. Where would that person start for care? So we notice that the hip's hurting a little bit of pain here and there. Does that person go to primary care first, their primary caregiver? Do they go to orthopedics? Do they go to physical therapy, rheumatology? Where does one start?
Yeah, the other two doctors on board will probably confirm that people come in typically with kind of three different hip pains, and some of which in our orthopedic realm isn't the hip at all, but it's more, low back or something going on there, which, for that standpoint, you wouldn't want a joint replacement surgeon, for example. But so we see that all the time. You can have hip pain that's coming from the ball and socket joint. You can have hip pain that's tendonitis or bursitis or something on the outer portion of the hip. And then you can have hip pain where patients are, immediately grabbed to kind of their posterior hip, which is oftentimes more related to their spine. So from that standpoint, the way to start, just simply screening any of those issues is usually just a basic exam and, talking with your regular doctor. Most of the time they would get a simple screening x-ray, mostly of the hip specifically, or the pelvis, and that oftentimes will even show a little bit of the low back. And then from there, again, Dr. Watson mentioned therapy frequently will help almost the majority of, say, low back issues or tendonitis issues, and even if it's an arthritis situation. So, we see the general term hip pain all the time, but you have to quickly start to determine, okay, which part of the hip and pelvis and back are we even talking about? And so most of the time it would just be starting with your primary care doc. They would typically do some simple screening exam and x-rays or whatnot, and then it would get moved on to the next person. So kind of like, in a way, I would be the end of that road, because you don't want to see the surgeon right away. So it might be somebody like, Dr. Wickman, who is evaluating all of that, maybe gets you into therapy, maybe figures out that it's actually more related to your spine. And then that would be a whole different provider. Again, not necessarily a surgeon, but a specialist that deals more with, spine issues. So that's kind of how we would start. Now, if you did end up in my office, just from an access standpoint, we would do the same thing. We would figure out, I would check if it's your back, if it's your tendons, if it's the ball and socket, and then start directing you from there. So.
Yeah, just to tie into that also, again, so many times we'll see people come in the office and they say, I've got arthritis, and they point to the bone on the outside of the hip. Well, that's more commonly bursitis, tendonitis, or potentially coming from your back, because the hip joint ball is actually more in the groin.
Right.
So it's the groin pain that is more particularly troublesome and more likely to be arthritis. And that's why I always joke. I tell my patients, okay, it's time to get up on the exam table so I can kick the tires and try and figure out what's going on. Because again, everybody experiences symptoms differently. And until you examine somebody, it's tough to say exactly what it is.
That is wonderful. And so I think the key takeaway too is that if you end up with Dr. Pierce, it's going to be okay. It doesn't mean you're going to go in for surgery. That's
exactly. Yeah. Even though I'm a surgeon, yeah, if somebody doesn't need it and you need something else, it's always the first, multiple choices there. So yeah, for sure.
That's wonderful. That's great. Dr. Wickman, one of the questions that I wanted to ask you is that we commonly receive a lot of questions about pain either associated with an injury or really just joint pain that is often worse at night. And, we've certainly touched upon this numerous amounts of times, but I wanted to see if you had any recommendations to kind of, is there anything that can be done to alleviate some of that nighttime pain to allow for better sleep at night?
Absolutely. So I definitely, when kind of talking through that pain and function piece, many people come into my office because they're like, Doc, it's waking me up at night. And that sometimes is the straw that breaks the camel's back, if you will, that brings them in to be evaluated. So kind of how we treat everything on a spectrum, if you will. I think usually the recommendations kind of just to start with certain injuries, certain joint pains, etc., are, not only just like both of my colleagues have mentioned, emphasizing physical therapy, using movement as medicine can be super, super helpful. But then at night, sometimes after a long day where we've used the joint pretty significantly, it can be achy, it can be painful. And that's where implementing some of those techniques to try to help take down some of that inflammation. So ice, sometimes if it's a muscular injury, sometimes heat can feel a little bit better. If your medical history allows, considering something like an anti-inflammatory medication, like an ibuprofen, Motrin, or Tylenol, as long as, like I said, your medical history allows, sometimes those medications can take down that pain a little bit, help you reposition a little bit better to ultimately help you sleep better. And then I always emphasize too, some of the most important things that we always call the sleep hygiene piece. So making sure you're doing everything to optimize your sleep, including, not being on our phones or TVs right before bed. All of those things can help keep you up at night. And then if you're already up at night, then you're also noticing your pain. And then it's a vicious cycle.
Then no sleep for anybody.
Exactly.
Wonderful. Thank you. And then actually going off of that question, Dr. Watson, I wanted to touch base with you. And, Dr. Wickman had indicated that some of those NSAIDs are over-the-counter, pain relievers. How long is it recommended that somebody take that for joint pain? Or is there a recommendation for the duration that somebody can kind of continue taking that?
Arthritis medicines, even though they're great at decreasing inflammation, they do have potential for significant side effects. Gastrointestinal, GI, like heartburn, acid stomach, sour stomach, those are some of the more common. Ulcers is the biggest concern, and one of the biggest concerns are, the arthritis medicines, the NSAID category, like the Advil, the Aleve, the ibuprofen, can irritate the lining of the stomach, can potentially cause a GI bleed. That's why people on blood thinners are not allowed to take those, because the risk of bleeding is already high in those individuals. They also can affect the kidneys. So if you have a concern for kidney issues, you got to avoid them, especially beginning of kidney failure, renal failure. They can also affect the liver. So a lot depends on the individual, but if you're going to be on them long term, it's critical to get blood work every year to monitor kidney function and liver function. I have people who live on those medicines, and unfortunately, you just got to monitor. It's about finding the right balance. I always say life is playing game, and you've got to manage the course between arthritis medicines, ice, heat, therapy, stretching, strengthening. It's finding that right balance to navigate these inflammatory problem and arthritis. It's nice if you are on them long term to take a holiday every now and again, just to let your body to recover, and then maybe start back it on again, maybe 2 or 3 weeks later. But it's critical to get the blood work, because if you start having problems with your kidneys, that's critical. So
wonderful. Well, not wonderful that would happen, but wonderful answer to that question. Thank you. Dr. Pierce, one of the questions that we often receive is, if arthritis is already in the body, is there anything that can be done to stop or hinder the advancement of arthritis?
That's a little bit of a loaded question. So arthritis, it's very multifactorial. Some of it's genetics, some of it's old injuries, some of it's work related, so a lot of it though is sort of environmental and different factors. So if you start to develop arthritis just because your mom had their knees replaced and your brother had his hip replaced, and it's sort of a genetic base, there's obviously things that, like Dr. Wickman said, again, keeping motion going, keeping strength up, making sure you do have good bone health and things like that. But there's other things where you can try to slow things. There's like anti-inflammatory diets, and there's all kinds of different health and wellness things you can do. But unfortunately for some people, if they had an old high school injury or something like that, and if their knee is going to wear out, their knee is going to wear out. So the most important thing for any joints, whether it's your back or your knee or your hip or an ankle or anything, is really maintaining some level of a strengthening program. And that doesn't have to be going to the gym or walking 5 miles a day on a treadmill. It can be very basic things like, just simple strengthening exercises that you can do even laying in bed, watching TV or reading a book, and you can be strengthening the thigh muscles, which then gives some added support for the knee joint, and then the knee joint feels better, even if it is, wearing out over time. So there are some factors that just unfortunately in life, we can't necessarily completely modify. But again, there's things like, and we talk about it a lot, and it's a hard topic probably for another day, but weight loss helps all of our, especially lower extremity joints. The reality is, for every 1 pound we either gain or lose, that's 4 to 5 pounds that our lower extremity weight-bearing joints see. So there are things that you can do. There's also things that if we have arthritis in various parts, other than some medications and different things, that it's just one of those things where you have to try to maintain as opposed to stop the process, if that makes sense.
No, that makes perfect sense. And actually, I have a couple of follow-up questions that maybe we can just kind of label them as more lifestyle questions to really elaborate on that. That was a great segue for that, because we often get questions like this about diet. And I don't know how often, you guys are watching TV, but there's a lot of supplements that are constantly being shown on commercials, and whether it be on TV or through social media, that it's kind of hard to navigate those waters to determine if this is something that's viable or is it not. So I'm really glad that you brought that up, because we have a ton of questions to kind of elaborate a little bit more on that. So this is great. So Dr. Watson, I'm going to pose that question to you to start us with. Is there anything that, when you're seeing somebody, that you can, is there any kind of confidence in a food or a supplement that you have seen or patients have told you, I'm really seeing a difference in my joint pain with this supplement or food source?
Awesome. So one of the biggest ones, especially when it comes to arthritis, is glucosamine chondroitin sulfate, sharp cartilage, MSM. Basically, our joints have lubrication in them. That lubrication, the major factor is hyaluronic acid. And the mechanical friction of the arthritis breaks down that lubricating factor. Imagine trying to drive your car on cooking oil. It's a cooking oil, but not the same viscosity of motor oil. The key behind the glucosamine chondroitin sulfate is you take it by mouth, it gets absorbed by the stomach, gets in the bloodstream, and some of that's going to end up in the joint. Some people respond great to it. They swear by it. It can take up to 6 months to get effect. Some people, it just depends on your stomach and absorption, your liver, how much is metabolized. They may not have it. Unfortunately, it's going to take up to 6 months, but if you have the medical resources, that's something that may work for you. One of the biggest things people are talking about is certain other supplements. Turmeric is a good natural anti-inflammatory medication that is hot lately. Again, it's just one of those things. I always joke, the medicine man would scrape the bark, they'd bring it in, they give it to the patients and cure the ailment. And then the scientists determine what the active ingredient was and turned it into a pill. So a lot of these dietary supplements are actually some of the basis behind some of the medications we have. And again, everybody responds a little bit differently, works a little bit differently. Sometimes you got to try multiple different things to find what works for you. Again, going up to the next step, with knee arthritis particularly, viscosupplementation, that hyaluronic acid, that's the injectable form. I'd always tell people it's like taking your knee in for an oil change. Basically, it helps to replace that viscosity and can be very beneficial at help to ease some of the inflammation and the joint pain. Unfortunately, the arthritis, the question is there any way to stop it? Once you get it, it's going to progress. The key is try and modify the activities that will aggravate it and do the things you can to decrease the inflammation, but it's all about maintaining that exercise regimen, the flexibility. I see people, they limp. And the more you hurt, the more you limp, the weaker you get, and that's that downward spiral. And then the dominoes start falling and you get all these other inflammatory problems. And that's why, again, just find what works for you. CBD is another hot topic. Is there any science behind that? Again, right now we're unaware of it, but again, whether it's placebo effect, if it works for you, great. It's another option to try that may give you some relief. Some people get benefits, some people swear by it, some people may not see any effect. Everybody's different. Find what works for you.
That is wonderful. Thank you. And you read my mind because I was going to the CBD question for you. So you read my mind and you answered it. Dr. Wickman, actually, I wanted to ask this to you. And I know that, you probably in your office don't see this as much because my guess is that you're seeing more athletes and, other individuals. But on the off chance that you have somebody that is consuming alcohol or smoking, is that something that's going to affect joint pain for someone?
Absolutely. And so I see athletes of all different ages, of different, sports, if you will. So whether that's a high school soccer player or a avid golfer who may be partaking in some of those activities while they're playing. I mean, we see everybody. And I do tell people that I think ultimately smoking, alcohol, those are things that can be detrimental to your health for several other things, whether it's your lung health, your liver health, increasing your risk of cancer. There's definitely a lot of detrimental effects for using those substances, particularly fairly regularly, but also can increase inflammation, which can in turn increase joint pain and prevent the healing process as well. So if you were to end up with an injury or something like that, that can decrease your potential to be able to heal, take much longer to be able to heal. So there are habits that we ultimately talk to people about in terms of trying to cut back or completely stop, if at all possible, to improve not only your musculoskeletal health, but your health overall.
Wonderful. Thank you very much. I do want to ask this question, and actually, I'm going to pose this question to you, Dr. Pierce. Is there any role, for women that are perhaps in menopause. Does that play a contributing role in muscle or joint pain for someone? And if so, how would that be addressed?
I think it's a similar theme that we've talked about before. It's really an important stage in a woman's health. And I think women probably have various different ways that their body, is dealing with that. And so as far as their musculoskeletal situation during menopause, it's the same thing. It's kind of like, it's really hard to get up and get going when you've had a long, tired day at work or something like that. But if you just come home from work and sit on the couch and do nothing, you're actually going to have more problems with your muscles or your joints or your whatever. And so when you're going through menopause, it's the same thing. There's all kinds of hormonal changes and fatigue, and not that I've dealt with any of that, but it's the same thing. It's important to maintain a regimen of, even if it's just a 15-minute stretching, session, that you start doing some, yoga. I mean, it can be anything that just simply keeps the joints going, keeps the body going, and then actually fatigue improves, and you can kind of battle going through that kind of thing with just just the basic concepts we've talked about. Again, even a session or two with formal therapy to maintain a strengthening routine and so forth. So I certainly would not suggest I'm an expert on life's changes and menopause specifically, but I do see patients all the time in that period of their life that they're going through these different things, and whether it's, again, like we talked about before, maybe it's their back has been bothering them more, their knees seem to be bothering them more, and it all can correlate back to just keeping things going. I saw a patient actually today, and for different reasons is having trouble, and we recommended some pool therapy, which it's not easy to do because not everybody has access to a pool, or not everybody has money to buy a membership to a local pool or whatnot. But pool activities, even if it's not swimming per se, but just literally getting into the pool and getting your body moving, is just so tremendous, for all of our joints. So there's all kinds of modalities, like Dr. Watson mentioned before, that just frankly can keep people going through the different stages of life. So
that's very helpful. And I can imagine, I know that we've certainly heard that. So if there would be any potential way, I know that all of us are here in Northeastern Ohio, but many of the folks that are tuning in might not. They may be in warmer weather, so they hopefully might have access to a pool, an outdoor pool. That would be very nice. But for us, I know we're kind of stuck indoors for anything indoors at the time being, at least. So thank you very much for that. Mm-hmm. I wanted to take a pause and kind of switch to a question that we just received, actually. So we talked a lot about injections and cortisone injections. One of the questions that we had, and I'm going to pose this to you, Dr. Watson, is I know that cortisone offers temporary relief for SI pain. Is there any permanent or long-term treatment to keep that specific SI joint pain from returning?
The sacroiliac joint, or part of the pelvis where the spine attaches to the hip area, is a high stress area underneath a tremendous amount of stress. Inflammation in that is a very challenging problem. Cortisone shots, again, put the anti-inflammatory medication right where you need it. Very beneficial. But one of the other things, it's about maintaining proper muscles. Core muscles are critical. core muscles help to stabilize the pelvis, to eliminate some of the motion. That motion is that grinding factor that leads to the recurrence of the inflammation, the recurrence of the pain. It's all about keeping that inflammation down. One of the things that I always say, that cortisone shot puts some medicine there, but if you're able to take arthritis medicines, that's another way to try and address the issue. Ice, heat, stretching, strengthening. Biggest thing is activity modification, avoiding the things that put stress on the area. Yoga is a good way to work on the core muscles, to help stabilize the muscles, to try and limit the motion there. The sacroiliac joint is a very difficult joint to deal with, just because of the fact that there's not a lot of good treatment options for it. And that's why sometimes it's even finding the right therapist to get you in an exercise regimen that helps to get you lasting longer between the injections. That's the critical thing.
Thank you very much. And kind of going off of that, we are receiving a lot of questions, which we always do, and we totally understand that this is a hot topic. So I'm actually going to get this one, if that's okay with you guys. But every single time we do an event, we gather a numerous amount of questions about if I'm a candidate for robotic surgery or hip resurfacing or ankle replacements, or if my shoulder pain requires surgery. And we totally understand those are all topics that are fresh on everybody's mind, and often popular topics that you might see on TV or social media. But we do want to stress that there are so many individualized factors that would really go into finding that appropriate diagnosis and treatment plan. And those are really decisions that are kind of best between an individual and their practitioner, whether it be anybody that you see, any of our three practitioners that are here. So we do see the questions, and we certainly aren't ignoring them, but oftentimes there's just not a general kind of answer that we can recommend for something like that, other than to recommend that you see somebody, because it is so individualized on one person versus another person. So just a quick note of that, as we kind of address some of the questions that we're receiving as we do this event. And we are doing I'm just absolutely enjoying our time here together. I want to get through as many more questions as we possibly can. So I'm going to kind of shift a little bit instead of our lifestyle questions. Dr. Wickman, I want to ask you about kind of an exercise question. So as somebody is aging, as they are older, at what point is there a point that the benefits of exercise outweigh any kind of potential risk of maybe getting injured?
That's a great question. And honestly, I would say for the majority of our lives, the benefits would outweigh the risks, just because we've touched on before, that using movement as medicine, being able to maintain that active lifestyle for as long as you possibly can, that is going to be absolutely critical to your health for the long term. So we always recommend, trying to be able to stay active as long as you possibly can. If you have questions about, whether that a specific type of exercise is something that, you are eligible for, or you are considering starting an exercise regimen, a lot of times we do recommend even just starting with your primary care doctor and saying hey, my health history best. We usually have a very long-term relationship. Would I be eligible to start pickleball, or would I be eligible to start a walking pattern? Whatever that might be. Sometimes that's the first place to start in terms of making sure that this is something that you're safe to do. However, we, especially in sports medicine, want to allow and try to be able to promote and help people maintain the activities that they love to do for as long as possible. And we'll try to do whatever we can to be able to work with you, come up with an individualized plan to be able to make sure that happens.
Wonderful. Thank you. Dr. Pierce, I wanted to ask this question. I know we were kind of joking about if somebody comes to see you, they're, not going to go in for surgery, but I do have a surgical question for you, and I want to make sure that we get to those as well. Oftentimes, I think that there is a great fear of hip replacement. And I think that one of the biggest questions that we have received for today's event is, will a hip replacement provide more mobility for someone or less mobility? Because it's kind of like that connotation of like you're not going to be moving as much. So can you elaborate on that by chance?
Historically, excuse me, hip replacements in general are one of the most successful surgical procedure that's ever been invented. That's not orthopedics, and that's not me saying that. It's like a phenomenal surgery for a lot of people. Yes, it's a big surgery, and yes, there's unfortunately things that can happen or go wrong, but the great majority of all people that have gotten their hips replaced, one after another, as long as everything goes okay, come in and say they literally, are pain-free. I mean, it's that much of an improvement in quality of life for people. So from just the basic question of, do they have more or less motion, by the time somebody typically would require or request or be indicated for a hip replacement, they've probably already lost a lot of motion simply because of the pain and limited joint from the surface wearing down. So just by the simple fact of having a nice, smooth, surgically replaced hip, they're going to gain motion. Now, is it normal motion from a hip that, you were born with? Of course not, because actually for most, not all, but for most hip replacements, there are some like restrictions that you have to maintain. There's not a lot, but sometimes there are some. But even with those precautions or precautions that we will give people after hip replacements, their ability to live their normal life and play golf and play tennis and garden and do practically anything they want completely outweighs any light restrictions that they might have. So, asking like, will I have more or less motion? Well, technically you're going to have probably more motion than you did with the arthritis. It's not going to be the same motion that you would have with a normal hip, but that's because we do have people have some very minor positional, like cautions. But for the most part, you basically just live what you want to be doing without much second thought. And from a pain relieving standpoint, it's kind of a no-brainer. It really is. Once you get to the point where you're having pain or functional pain from your arthritic problem in your hip joint, you have to have a really candid conversation with the doctor about that. And even though nobody really wants to have surgery for anything, but this is really something that it's definitely a quality of life changer for almost everybody that goes through it, for sure.
Thank you very much. Dr. Wickman, I have a question for you. So let's say someone has a sports injury. I myself have torn my ACL on the slopes, and it was not fun at all. But let's say somebody has an ACL tear or a meniscus or an MCL tear. Is that something that only requires surgery to fix it, or are there non-surgical ways to repair or live with a torn ACL? Or maybe you can elaborate on that.
Absolutely. So I think ultimately it truly is an individualized decision, and it depends on so many different factors. So a lot of times we take into account not only their age, but what they like to do. If they are somebody who tore their ACL playing soccer and want to get back to playing soccer, then they will likely need a surgical management for that. Whereas if it's somebody who did have a skiing accident and they're like, after that, I'm staying nowhere near the slopes anymore. And for exercise, they don't do a lot of cutting motions. They are pretty much, they like to go on walks, but they're staying on fairly even surfaces. It's straightforward. It's something that, we can talk about, maybe not necessarily needing to go down the surgical management route. it's very challenging because, like I said, it depends on the individualized person. But I always tell people when they're in my office, I'm like, I am not the surgeon. So, if you are interested in at least hearing them out and having a surgical opinion, we facilitate that that handoff very, very warmly and very easily. However, at the same time, if they're like, Doc, I came to you because I want to stay out of the operating room, which is what we do see a fair amount, we'll talk through any sort of options. I think physical therapy for that is absolutely critical to be able to make sure that all of the surrounding musculature is nice and strong to help stabilize that knee that doesn't have those ligaments that are stabilizing it. So that's something that we can definitely talk about. Will physical therapy cure an ACL tear? No. But there are many people that are walking around with some wear and tear to their meniscus, and they do really, really well with physical therapy. They don't require a surgery. So it is, to answer your question, it's a very individualized decision that we talk about in the office, but may not necessarily 100% require surgery based on their lifestyle.
Wonderful. Thank you. That is good to know. A few years too late for me, but that's okay. Dr. Watson, I want to get you involved. So I'm going to ask you a question. I'm going to shift a little bit instead of hips and kind of going off of those knee topics. If somebody does have just straight bone on bone in their knees, is a knee replacement the only option that that person may have?
No, it's not the only option. And one of the frustrating things is the fact that we sometimes see individuals who said, well, I'm not ready for surgery. I'm not ready for surgery. I'm not ready for surgery. And then they run into a medical problem, whether it be heart issues, kidney issues, and then all of a sudden they're not a candidate for surgery. And that is a very difficult situation. So timing, you don't want to wait too long because you don't want to burn bridges. It's finding the right time. And that is always a difficult decision when the non-operative stuff stops working. Again, there's always ways to get around. And I had a good friend of the family at 97 years old. She was getting Synvisc injections, that visco supplementation every 6 months. And her knees looked horrible, but she was still motoring around with her walker, getting around. And she needed a knee replacement probably 20 years ago. But she was able to modify her activity, use a walker, use a cane. The visco supplementation helps. And I have individuals who literally every 6 months they're back in the office to get it, because if you can keep the lubrication up and keep that inflammation down, it prevents from those acute flare-ups that make that pain absolutely 10 out of 10, up at night miserable. And again, everybody's different, but it's learning to modify the activities. It's using a cane when you need to, just using a cane in the opposite hand. And people say it's the opposite hand. So if you have a bad right knee, you put the cane in the left knee or the left hand, and the left hand cane moves with that right leg. And that'll take 50% of your body weight off of that bad injured extremity. And it's amazing how well that can do to keep the inflammation down. So again, it's finding whether between cortisone, visco supplementation, PRP, those are all different ways to keep the inflammation down. And even with some of the worst arthritis, I see people get around like crazy because there's no inflammation there. It's about keeping the inflammation under control.
Wonderful. Thank you. I think one of the body parts that we haven't talked too much about, so I'm going to switch focus here, is to our hand and wrist. And I know, we often kind of hear a little bit more about this lately as we kind of move our mouse around or we text with our thumbs. So this is definitely something that is a big topic now. So Dr. Pierce, I want to ask you first and foremost, what would, let's start here. What's the difference between carpal tunnel and arthritis?
Yeah, that's actually relatively easy. So both are super common. I think I saw maybe 12 patients this morning, and maybe half of them came in with some symptoms from arthritis and half of them came in with some symptoms of carpal tunnel. So the biggest designation, just to split the difference there, is carpal tunnel is almost uniformly more of a sensation kind of a situation. So whether people describe it as a numbness or a tingling or a burning or a fuzziness or anything like that, that starts to lead you down more the line of a nervy kind of thing. And that's what carpal tunnel is. Carpal tunnel is the nerve that comes down the center of the wrist. And if it starts to get irritated, that nerve starts to give people symptoms that a nerve would. So that's numb and tingly, and it wakes you up at night, and you're driving and you feel like you got to shake your hand out. Whereas arthritis is more a feeling of either stiffness or soreness or, motion that is either painful or, carpal tunnel, if you're just moving your fingers, doesn't necessarily cause you pain. Whereas if your thumb has bad thumb arthritis, you could just be pulling on your socks and, that's going to hurt at your thumb or at your wrist or at your finger. So the difference between, just purely and simply arthritis versus nerve symptoms, that can be readily addressed or figured out just within even a few questions, as common as both of them are. They're both probably equally as common for patients to show up. And then it's just a matter of asking just a few simple questions to determine which of those. And then, of course, they have vastly different, paths of treatment. So, but certainly both are extraordinarily common.
Wonderful. Thank you. And are there any kind of recommendations that you might give to somebody to strengthen their wrist? I mean, or even their grip strength? Is there any kind of recommendations for something like that?
Well, in general terms, I think a lot of folks come in and say, can I just use a squeeze ball or one of these spring-loaded grippers or something like that? And to be honest, that's probably a little bit too much. A lot of times, for whether it's the thumb or the fingers, whether it's somebody that's a little bit older and has some arthritis, those spring-loaded gripping things that you can get at the store, those aren't easy to do, and you can't really get even a full, fist with those. So there's a lot of different putties and whatnot. You can literally just go on Amazon. It sounds as basic as it is, and type in hand putty, and they have extra soft, and using a putty to start to strengthen up your hand or your thumb, even with pinching and things like that, is much more effective than trying to, use some sort of like squish ball or something like that. And again, as a similar topic, whether it's a hip or a knee or whatever, I mean, just simple motion. I see so many patients that come in and their hand is stiff, and, and a lot of that's related to some pain, maybe again, what Dr. Watson was saying, inflammation. But if you just simply are making sure that you're stretching your, those knuckles in your fist on a routine basis to try to make sure you're getting as much motion as you can, then you're already one step ahead in kind of like battling things like this. So, and then again, a step up from that is having you see one of our occupational therapists, which they're specifically trained in upper extremity things. So from a strengthening standpoint or a daily task that somebody maybe is having more difficulty doing, the hand therapist or the occupational therapists, in a similar way that the physical therapists take care of people if they've got, a knee that's not as strong or a back that needs to be tuned up. It's the hand therapist or the occupational therapist that will help people more specifically with the hand, the fingers, the wrist, even up to the elbow and so forth. So, yeah.
Thank you. Dr. Wickman, I have a question in regards to shoulder pain. When would someone know if they should stretch or exercise that shoulder or continue on with their exercises or stretch that shoulder versus when to not push it?
Kind of similar to like maybe the first question we talked about. But shoulder can be a little bit challenging because there's so many different structures in that area. Could it be just like Dr. Pierce was talking about with the hip? Could it be the ball and socket joint of the shoulder? Could it be the surrounding tendons? Is it the bursa? Is something getting pinched? I mean, could it be coming from the neck and there be a nerve that's radiating to that area? There's so many different possibilities to what is truly causing that pain. But what I tell people, kind of similar to what we talked about before, If it's a little bit sore because you were out raking leaves, not necessarily surprising. That should go away fairly quickly, though. If it's something that's sticking around or is really getting in the way of what you're able to do, or if there was an injury of some sort that's preventing you from really being able to move the shoulder like you were able to before, feeling decreased strength or anything like that, that's when coming in for an evaluation, really trying to hone in so we can figure out, hold on, what are we treating? And then coming up with that plan to be able to help approach that in the best way. That's when I would say, if it's sticking around or getting in the way of you being able to do things, that's when I would come in.
Perfect. Thank you. We're going to ask one final question, and this is a very fun question because I get to ask all of you, and it's a personalized question. So I'm going to start with you, Dr. Pierce, and this is going to be, Dr. Watson and Dr. Wickman get a little bit more time to think about it, but our question is, what is one thing that each of you do in your own personal life to take care of your joints?
Well, up until recently, I enjoyed just throwing on my shoes and going for a jog, but I personally have been having a little bit of knee trouble too. So just in some of the topics we've been talking about, I've had to make some, alterations and changes. So whereas up until this has been bothering me, I would just, if I had time, whether it was after work or a day in the morning, I would just go for a simple jog, and I would do what I was comfortable doing, whether that was the pace or the distance or the track that I went on. But since my knee's been bothering me, I haven't been able to run for a while. So I've had to change it up. I've been doing a lot more of some of those actual exercises that I actually was talking about earlier with just strengthening up that knee. I've been taking some anti-inflammatories and whatnot. I've been having to deal more with just simply stretching routines, which are good for all of us. I think sometimes we don't pay attention to that as much. For example, I'd throw my shoes on and I'd go for a run, and I wouldn't probably warm up the way that I should have been, but this is forcing me to do that, especially now that I can't just go for a jog. I've been doing a lot more stretching routines, the strengthening exercises that I hand out to people, and I did even this morning. I'm doing those exercises myself. So for me personally, it's, just trying to more be disciplined with finding, even if it's 15 or 20 minutes a day of anything, doing anything for 15 or 20 minutes is better than doing nothing. So even, if you just have a little bit of time while you're watching Jeopardy at night or whatever you might enjoy doing with your family, if you're doing something for 20 minutes, that's better than not. And so you just have to kind of find your something that you enjoy and just be disciplined enough to do it on a routine basis, really.
Wonderful. Thank you. How about you, Dr. Wickman? What is one thing that you do?
Yes. So I think, just like Dr. Pierce said, I think the key is finding something that you're excited about, that you enjoy doing, to be able to maintain that motion, because as we've all talked about, motion is so important. So I have since hung up my soccer cleats, but now I am fully invested in the almost cult that is spinning. So I go to an indoor cycling studio, and I really like being surrounded by so many other people. The community aspect to exercise I find to be really, really helpful and beneficial. It's something that I go to actually with my mom. So it's nice because I actually get to see her doing that, and, promoting active lifestyle within our family, which I think is important. But I think that has been something that I've really, really enjoyed doing, and would recommend. If you're looking for, trying to find a new exercise routine, considering going to a class or something where there's an instructor and they can kind of walk you through expectations, and then you have others that are around you motivating you and cheering you on too. I find that to be super helpful, and is something that I'm now passionate about.
I love it. Thank you very much. And lastly, you, Dr. Watson, what is one thing that you do to take care of your joints?
So one of the biggest things is with some of my own orthopedic issues, as Dr. Pierce mentioned, getting old is not fun, but I do a lot of power walking. to me, it's all about core stability. And as I'm doing that, I'm concentrating on core, proper posture, proper techniques. It just helps to maintain proper muscle mass, help to maintain some of the flexibility. I used to be a runner, but unfortunately, my joints will not allow that anymore. So I've step back, concentrate more on power walking. Again, better on flat surfaces. If you're on a treadmill, no incline. Again, I encourage patients like Dr. Wickman, Dr. Pierce, who said, find what works for you. There are so many different type of exercises out there. Keep moving. And if you have, say, a partner that keeps skin in the game, that on those days you're struggling, they encourage you to get out there, that's critical. Just keep moving is the most important thing.
Wonderful. Thank you so very much. I cannot thank all three of you enough for being here with us, answering these questions, and of course to everyone in our audience for tuning in today, whether it be live or watching a recording, and just being here with us and submitting the questions, not just today, but over the course of the year, over the course of this virtual event series. We have really appreciated it. And hopefully we have answered as many questions that you might have as possible, but we will certainly continue on with these events, so stick around for that. What is coming up next, I do want to share that in about a day, you will receive, if you have registered for the event, you will receive an email from us here at the clinic that is this recording. So you will have a recording of this event. You can go back if you are, maybe you stepped away from your computer, or maybe, you're thinking of somebody in your head that would really benefit from watching this. You can certainly share with them as well. And then, of course, as we had mentioned at the beginning, in our handout section, there is some really wonderful resources for some additional information and some of the pieces of information that we here at the clinic provide. So with that being said, we want to again thank all of our presenters, all of our speakers for being here with us, for taking the time out of their day to do this. We thank you all so much, and we hope you all have a wonderful rest of the day and year.
Thank you.
Thanks, Diana. Thanks, guys.
Thank you.
Have a good day.